Hi, I'm Jenny Morrell, and today we will be discussing how to manage high-risk medications in the elderly population. So we're going to talk about issues that affect the elderly specifically, as well as some of the pharmacokinetics that affect the elderly and their medication absorption. And then we're going to discuss some of the nationwide initiatives to help improve the medication management within the elderly population. And then I want to leave you with a few clinical pearls and some tips to hopefully help your facility and you as an individual nurse manage these medications or help teach the elderly how to manage these medications. So let's get started. So age, of course, is one of the biggest issues that we tend to think about when we talk about the elderly and the aging population. So the advances in medicine, of course, allow the patients to live longer. So we have a high rate of senior citizens within our communities. And according to Healthy People 2020, there are about 52 million adults age 65 and older. And these individuals are the largest consumers of our health care nationwide. And of course, as we age, our body systems age, so they tend to have a lot of ailments such as, heart disease, diabetes, COPD, renal disease, cancer, arthritis, dementia, and all of these chronic, long-term disorders weaken the immune system, making them prone to, viral and bacterial infections, as well as, some medication non-compliance or difficulty adhering to medications. And polypharmacy is described as when a person takes more than 5 medications on a daily basis. So the average number of medications that an older adult or a senior citizen takes is about 11 per day. And that's a lot of medicine. Not only is that, oral medications or pills or elixirs, but, you have to think about inhalers, breathing treatments, sub-Q, injections if they're diabetics. So that's really a lot of medicine. And not only is it medications, but you have to think about the over-the-counter supplements as well. So, Tylenol or Motrin or Aleve, they're daily vitamins or herbal supplements that could possibly, interact with their medications. And then sometimes the elderly get confused between the generic and the trade names. So there may be a possibility that they're taking more than prescribed. So for example, they have a prescription for furosemide, which we all know is Lasix, and then they also have, a prescription for Lasix. So they actually may be taking more than prescribed because they think those are two different drugs. And also having more than one doctor prescribing medications increases their chances of having polypharmacy. And medication adherence, there's lots of different issues affecting the elderly that affect their ability to stay on their prescribed medications. One of which is, difficult eyesight. As they age, it makes it very difficult to read prescription bottles and see labels. And then also their limited range of motion in their joints make it difficult to open these medication bottles. And then if they have dementia or intellectual decline, sometimes it can make it difficult to remember to take a medication or follow a medication schedule. And then sometimes this can lead to double dosing because they take the medication as they are supposed to, but then they forget that they took the medication. So oftentimes, they will, double dose or overdose, which can obviously lead them to, the ER or have an inpatient visit. And then our economical factors are very important as well. So senior adults, they live on a fixed income, and the continual increased cost of living makes it difficult for them to, pay their bills. It makes it difficult to buy groceries and afford their medications. So they may be presented with a choice. Do I want to pay my light bill this month, or do I want to get, this life-sustaining medication? So factors affecting the pharmacokinetics, or how medications are absorbed. Pharmacokinetics is the process in which the drugs are broken down, absorbed, used, and secreted by the body. So the four main categories, of course, are absorption, distribution, metabolism, and excretion. So there's two main factors that affect the drug absorption. So one, of course, is the GI tract, and the other is the musculoskeletal system. So the elderly often have delayed gastric emptying, so that as we age, our body processes slow down. So this can cause a medication to sit in the stomach for a longer period of time. So of course, this increases the unpleasant side effects, such as nausea, or vomiting, or even possible GI irritation if it sits in the stomach too long. And then decreased muscle mass affects how quickly medications are absorbed into the bloodstream. As we know, as we age, our muscle mass does decrease. And so if you don't have a good muscle supply, then we can give them IM injections all day long, but they're not. You got to have muscle mass and blood vessels within that muscle to absorb that injection. So the IM injections sometimes aren't always effective due to that decreased muscle mass. And then furthermore, with heart disease, that can further prolong absorption either through the GI tract or through that decreased muscle mass, because the heart's not pumping blood effectively to those to the stomach and to the muscles. So next we have metabolism. And there's two main factors with metabolism. So one is the liver, and then the other is, our genetic makeup, or, our race or ethnic background. So metabolism is how drugs are broken down by the body. So the liver is kind of the key spot where most drugs are metabolized so that our bodies can actually use them. And around 60 years of age, the liver begins to decrease in size and, slowing down the rate of absorption, or the rate of the drug metabolism to be absorbed and to be used by the body. So of course this causes a longer half-life of the drug and can increase the adverse side effects of the medication. Because again, if the liver can't break it down to be metabolized by the body, then it stays in the body for a longer period of time. So for example, if you give a patient, a sedative such as, Ativan or possibly Xanax, this is typically why a lot of older adults, they will stay in that kind of sleepy kind of hypnotic state for a long period of time. Like it really can knock them out. Whereas, a healthy 20 or 30-year-old can process that medication within a normal length of time. So this is very important when we talk about dosing for the elderly. We do have to think about, the liver and their ability to metabolize that medication. And then, various racial and ethnic backgrounds are more prone to higher or slower rates of metabolism. So, for example, Asian Americans tend to metabolize drugs quicker than our African Americans or our Caucasian patients. So sometimes this requires them to have a different or a higher dose of medication than maybe normally prescribed. So it's really true that one size does not fit all. We have our standard dosing, but that may need to be tweaked depending on, what the patient's race or ethnic background is, or their liver function. Next, we have drug distribution. So distribution is how this drug is delivered to the body once they are absorbed. So the key components here are body weight, body fluid, and protein. So body weight, of course, is probably one of the biggest. Many drugs that are commonly prescribed, such as heparin or sometimes Coumadin, and even sedatives, are often weight-based. And so weight fluctuations can cause an overdose or can possibly increase the side effects of medications. And then alterations in body fat can also affect the distribution of your fat-soluble vitamins as well as anesthesia. Anesthesia obviously does hang around in the body for a long period of time. So the more somebody weighs, the more like anesthetic that is stored in that body fat. And the same thing with your fat-soluble vitamins. So a person that, looks anorexic or is not eating well and is losing that body fat, they're not going to have a good storage of those fat-soluble vitamins. So it can cause nutritional issues, as well as their body processes that uses those vitamins. Your fat-soluble vitamins A, D, E, and vitamin K are going to be altered as well. And then body fluid, of course, it is big in the elderly also, because a lot of adults suffer from dehydration and, of course, decreased water volume within the body. Sometimes they forget to drink, or sometimes with brain injuries or stroke, that thirst mechanism is altered, and so sometimes they forget to drink. So this can increase the toxicity of your water-soluble medications and your water-soluble vitamins, as well as some antibiotics, because if you don't have enough water to distribute them, then you're going to have an increased concentration within the body. And you also have to have a healthy level of protein. One of the biggest proteins is albumin, and so this allows medications to be transported to the target tissues or to the target organs to do what the medication is supposed to do. So a low protein level due to poor nutritional intake or decreased appetite means that the smaller, you don't have that protein vehicle to carry it to the tissues, so smaller amounts of the drugs reach the organs. Therefore, they don't tend to have their desired effect. So last but not least is excretion. So once the medicine is absorbed into the body, it is broken down, it is metabolized by the liver, and it is distributed to the tissues. Once the body uses what it is going to use from that medication dose, the body has to excrete the rest of that medicine or that drug. So two factors are involved in excretion: the kidneys and the bowels. So the kidneys help excrete our water-soluble substances. And the elderly people often have, diminished blood flow, again due to disease processes, to the kidneys. And then oftentimes they will have decreased renal function. So they're not able to effectively clear these medications through their kidneys. So us as nurses, it's important to assess that their kidney function is healthy enough to clear or take the medication that is prescribed. And so one of the ways that we do this is the creatinine clearance. And then, of course, the elderly also, again, suffer from the decreased gastric motility. And constipation is a big deal within that elderly population. And so this can slow down the excretion of the fat-soluble drugs through the bowels. So how does this relate to health care? Or why is it such a big deal for us as healthcare workers? Well, for one, it causes unnecessary hospital visits and admissions to our facilities. So med errors are one of the most common reasons, or overdoses are one of the most common reasons that people over age 65 seek treatment. So these visits some of them could be actually, decreased with the proper medication administration and teaching. But without that, they clog the ER, so they cause a backflow in the ER, and then they create a shortage of beds on the inpatient units. And as we know, right now with the pandemic, the corona pandemic that we are suffering through, shortage of beds, is a big deal. So it's estimated that approximately 700,000 ED visits and over 100,000 hospital admissions occur each year due to either the underdosing or the overdosing of medications. And mostly this is patient dosing, the patient or the caregiver giving the medication. And so the most common medications that are reported to be overdosed on or medication errors are made, the Health and Human Services say that they are anticoagulants such as Coumadin and Lovenox, your diabetic medications, sorry, that's a mouthful, insulin, metformin, glipizide, and glyburide. The opioid analgesics such as morphine, hydrocodone, oxycodone, and fentanyl. And then all of your hypertensive medications. And then your benzodiazepines. So medication errors are very costly to treat. So according to Joint Commission, the medication errors cost about $3.5 billion, and then this increases yearly. So this includes the nursing care. This includes the actual visit, whether it be inpatient or through the ER. The medication or the antidote needed to treat the patient if it's an overdose. Also, the medications that need to be tweaked or managed. And so then this cost is passed on to Medicare and Medicaid and private insurances. And then, of course, this raises the co-pays and healthcare costs for everyone. So it's not just the elderly that's affected, but it's also, a healthy person. If they go to the doctor, maybe next year their copay will be higher to help cover the cost of the visits. And then medication errors can also cause long-term damage to patients, and then of course it increases their mortality. So for example, an overdose on Coumadin could actually thin the blood so much that it can cause the person to have a brain hemorrhage. So this may result in permanent loss of motor function and thought processes, or they can even have brain hemorrhage to a greater degree to where it actually causes death. And then of course our underdosing, particularly with our diabetic medications, can attack the eyes. They can also attack the kidneys. In fact, dialysis, one of the leading causes of dialysis is out of control diabetes that attack the kidney and cause permanent damage. And then of course our overdosing of our opioid medications can obviously cause life-threatening issues. So that person may have severe respiratory depression to the point of death, or if they're brought to the ER in time, then that person may have to be on a ventilator until their respiratory function improves. So some of the professional organizations realize that this is a big issue amongst our elderly patients nationwide. So we have several initiatives through Healthy People 2020, the CDC or Center for Disease Control, and then Joint Commission. So their goals are to raise awareness not only for us as healthcare providers, but also patients and their caregivers or their families. So Healthy People, right now we have Healthy People 2020. This is a 10-year campaign for, nationwide for health. I believe that the Healthy People was started in the 1990s because we had Healthy People 2000, and then every 10 years they establish goals for 10 years, and then once it gets close to the 10 years they evaluate, did we meet these healthcare topics? Where are we nationally in meeting these topics? So they will revise them every 10 years, and new topics and objectives are made based on our population's needs. So Healthy People 2020 had 42 health topics, but the main two topics for the elderly population is the older adult and medical product safety. So the older adults topics include improving the quality of life for adults 65 and older who are living with chronic diseases. So to do so, the objective was to increase healthcare screenings, immunizations, and to increase caregiver involvement in the patient's medical process, disease process, and of course medication teaching. So this topic also stresses the importance of using community resources such as home health agencies, hospice, and community centers to help bridge the gap between the hospital as well as the physician's office. And the goal for medical product safety is to increase the safe use of medical devices and medications. So the objectives for this topic have focused on improving the health literacy by making prescription bottles and teaching handouts easier to understand. And if they're easier to understand and easier to see, then the theory is that it will reduce the overdoses of high-risk medications such as your anticoagulants, your insulin, and your opioid medications. And the Center for Disease Control has an action plan for adverse drug events. So this started as part of the Affordable Care Act back around 2005, 2010. So the the Action Plan for Adverse Drug Events, or ADE for short, identifies the most crucial high-risk meds such as antibiotics that need therapeutic levels, anti-neoplastic drugs such as your chemotherapy drugs, your anticoagulants, insulin, opioids, and benzodiazepines. So the CDC found that when these medications are used, it increases the length of hospital stay between 2 to 5 days on average. So the CDC is working with the Department of Health and Human Services to develop an action plan for ADEs. And again, it did start from the Affordable Care Act, which means that it does try to reduce preventable complications and, of course, improve the quality of health care. One of the other initiatives for the ADE plan is to focus on increasing the technology in rural areas for hospitals and the outlying clinics and physicians' offices. This has to do a lot with the meaningful use that is tied to reimbursement. So if a patient goes to a inner city hospital or a big teaching or research hospital, but they live in a rural area, that doctor's office or that clinic that is doing their follow-up care may or may not have access to that hospital's records, or they may not be using the same system. So in return, you get sometimes fragmented care. So the goal for the ADE plan is, again, get these rural areas on board using the same electronic documentation systems as some of our bigger hospitals within the community. And this is very important because it can reduce the inappropriate drug dosages. They can do drug-to-drug interactions, and then it can also flag potential reactions to medications. So for example, if a patient is on a opioid drug and the doctor goes to prescribe something for sleep, then it can, if those two medications interact, or if it increases the effects of one medication or the other, then that doctor may get a red flag and see, oh, well, you were on, morphine, or you were on hydrocodone for, your back surgery. So we may need to hold off on the sleeping medication. And the ADE plan also stresses the importance of using the whole team-based approach. So from physician to pharmacist to review medications. So pharmacy our pharmacy representatives, even in our inpatient and our outpatient pharmacist, that's what they go to school for. That's what their degree is pharmacology. So oftentimes they can help nurses as well as prescribers, physicians and PAs and NPs, and help them, see if this medication may or may not be in the best interest of the patient. And then further initiatives, of course, have not been reached for the ADE plan, but one of the future goals for this plan is to work with outside pharmacies, such as Walgreens or CVS or Walmart, to actually see the patient's prescription trends in real time. So what this means is the pharmacist can actually send information electronically to the patient's doctor, so the patient's doctor can actually see how often they fill their prescriptions and if they've missed doses or if they've skipped their monthly dosages. So that could be very beneficial in the future. So Joint Commission is very much focused on the actual inpatient part of medication administration and documentation, as well as teaching. And Joint Commission's goal is to basically create a culture of safety within our hospitals. And as we know, they come and assess our hospitals every few years to just make sure that we are staying up on evidence-based practice, to make sure we are following protocols, not only hospital protocols, but the actual guidelines set forth for practice. So it really is a good, beneficial thing, even though it doesn't always feel like it. So Joint Commission's campaign is called Leading the Way to Zero. And so the focus on this goal is to not have patient harm of any kind. So this doesn't mean that there won't be mistakes, because obviously when you have humans doing a job, there is always going to be a risk factor for errors. But this just means that it does not actually cause permanent harm or cause a sentinel event for that patient. And so Leading the Way to Zero uses a top-to-bottom approach to raise safety awareness, whereas it starts with leadership, and leaders are trained to recognize the importance and the significance of error prevention, and then they train the staff that are actually performing the bedside care. And then we all know they have National Patient Safety Goals. So the National Patient Safety Goals are revised on a yearly basis. So basically Joint Commission takes all of the data that they have collected within a year, and they assess that data to identify patients that are at risk, identify medication or medical processes that are broken, and then they come up with the National Patient Safety Goals. And so the National Patient Safety Goals for 2021 that have to center around medications include labeling medications that are used for procedures, such as IV medications during preparations, labeling medications that are in oral syringes, as well as medications that are being infused, such as your critical drips and your IV fluids. So basically, anything that you are giving the patient needs to be correctly identified and correctly labeled. And then also, patients that are on blood thinners, we need to take the proper precautions for these patients. Make sure that the labs are drawn. Make sure that the patient's weight is correct, and that we are indeed giving them the correct dosage of medication, as well as making sure that that patient follows up with that doctor to get those, or outpatient clinic, to get those labs drawn and to get that medication properly adjusted. And then diligent medication information. So this includes the medication reconciliation from start of care onto when we transition that person out of the hospital to wherever they're going, whether it be home, whether it be a assisted living or rehab situation, and even getting the correct medication MedRec to their follow-up provider. So literature identifies several key areas where medication errors do occur. So this is the admission process, during medication administration, whether that be with nursing administration or patient or caregiver administration of the medication, teaching, and then of course transitioning to the patient's environment. So during admission, a MedRec is crucial. When a patient comes through the ER, we don't know what medications that they're on. We don't know what they're taking. So this is very important to get those medications down and get the whole picture of the patient's medical health. So it should be done at every admission, even if it isn't an inpatient stay. So if they come into the ER and they're treated and discharged, they still should have a medication reconciliation within 24 hours of that admission. Usually this is done on, if they're not inpatient, usually it's done before they are discharged. And it should include every single medication the patient is taking, that we know of to the best of our ability. Also, things that can help a medication reconciliation be a smooth process is for us to actually physically see the medication bottles and not just rely on a list. A lot of patients think they're doing us a favor by having a nice, neat list of the medications they take, and that is good. It really is good, but sometimes those lists aren't always updated. And so Joint Commission found that 62% of medication reconciliations were more accurate when the nurses examined the medication bottles instead of just relying on a list. And the bottles also can give us clues about the patient's health history, if the patient's a poor historian. And they can also verify whether or not the patient is actually taking the medication, because we can look on the bottle and see when it was last filled, and then we can do a pill count to make sure the patient's actually taking it as prescribed. And then also, we all know we've had patients where they come into the ER and you say, is this all your medications? Or are you taking these, medications or any medications at all? And sometimes they'll say no. Well, or do you ask them if they have a history of, heart disease, and they say no. But for example, they're on lisinopril, they're on Coumadin, and they're on a cholesterol medication such as Lipitor, and it kind of clues you in that, hey, maybe they do have, a history of heart disease. So then when you question them a little further, they're like, oh yeah, I had a heart attack 6 months ago. So that's why, the bottles are very important. And then also asking the patients about high-risk medications. So for example, when was the patient, last time they had blood work done to assess their body systems? So when was the last time they've been to the doctor? When did they have those labs drawn? And then when was the last time, if they're, diabetic, when was the last time they had their insulin? And then if they can't remember, or maybe it's been a while, then we do need to pass this on to, the nurse practitioner or, physician that is seeing that patient, because we may need to draw those labs to get a baseline or check that blood sugar to make sure that, they don't need that insulin. And then also including the patient and or, the caregiver, if they're available. During admission, sometimes a patient's usual medications may be discontinued, or there may be contraindications. So for example, if the patient comes in with a low blood pressure, obviously they're probably not going to be taking that, that medication to control that hypertension until we get that blood pressure under control. And then sometimes they have new medications ordered to treat their issue. So maybe there's a new medication or a formulary that works, just a little bit better than their old medication to control their disease process. So anytime we change those medications or we add new medications that they may or possibly may not go home on, these need to be communicated as soon as possible. And then we need to start teaching them, as soon as possible about the side effects and the schedule and the purpose of that medicine. Because medication administration centers around the nurse and the patient, I did want to include some tips for nursing administration. So obviously, one of the things that we can do is view the med rec when you're receiving the patient into your care. So whether this is your start of shift or whether you are receiving this patient, from the ER, or even from another department in the hospital, such as surgery. Make sure that we look at the medication reconciliation, and that we compare that med rec to the physician's orders to make sure that the medications are entered appropriately, and also to make sure that we have all of the medications on the list. And then of course we also need to ask the patient about, again, over-the-counter drugs and any herbal supplements that they may be taking, because these can affect the drug levels within the body. One that I know for sure is garlic. Garlic can actually cause blood thinning in some degree. So obviously this may interact with the Coumadin or the heparin or Lovenox that we're giving them to actually prevent blood clots. Another thing that we can do as nurses to make us better at medication administration is educate ourselves on the look-alike, sound-alike drugs, as well as the commonly given medications on our unit. So no matter what floor or what unit you work on, there's usually a few medications that pretty much everyone is going to be on, or you're going to give it, at some point within your shift. So educate yourself on these drugs. Look at, the pharmacokinetics of the drug. How long is the half-life? What's the standard dosage? How long is it supposed to be pushed over? What are the common side effects of this medication? As well as, the common adverse side effects. So if a patient starts experiencing those, then, we know to watch out for that and then notify the healthcare provider. Also use safe medication administration. So don't skip any safety checks in the medication systems, including, labeling the medications or even getting it out of the electronic medication systems such as the Pyxis or the like the Omnicell. Pay close attention to the units of measurements. Remember that milligrams, milliequivalents, and milliliters are not the same unit of measurement. And then, of course, always use your secondary verification for your high risk or your weight-based medications to ensure that the patient gets the proper dosage. And then we also want to exercise our nursing judgment and then verify the patient data prior to medication administration. So if it is time for a patient's scheduled narcotic and the patient is asleep or difficult to arouse, then maybe we need to hold that medication until a more appropriate time to prevent drug overdose. And then last but not least is evaluation. So always assess the patient's response to the medication. So if the patient has an adverse reaction, we do need to notify the healthcare provider as soon as possible. Or if the patient could be at high risk for bleeding or falls or even possibly mood changes, then we might need to advocate for a different less potent medication that will control that patient's illness. So this slide focuses on medications during the patient administration. So for example, what we as nurses need to do to ensure that the patient has a smooth process or the patient's caregiver has a smooth process. So we do need to assess the patient and the caregiver's ability to actually manage the medications. In order to prevent errors, they have to be able to do this. This is a crucial step in preventing medication errors. So consider the patient's ability to physically manage their own medications. So we need to take into consideration the patient's mood, their cognitive ability, their eyesight, their dexterity and the ability to handle the bottles. And then we also need to assess the caregiver's ability and commitment if the patient cannot manage their medications. So just because we teach a patient's caregiver in the hospital or at discharge, are they actually going to carry that out within the home setting? It doesn't do any good to teach someone about the medications or get them involved if a medication needs to be taken 3 times a day and the caregiver is an EMS that provider that works 24-hour shifts. They're obviously not going to be there to make sure that patient gets that medication 3 times a day. And then also we need to help the patient, find their why or find their motivation for medication compliance. A lot of patients, we gotta help them find that motivation, and then be prepared for discussing the consequences of not taking a medication. So, for example, patients, they don't understand that if they take a medication to manage a disease process, that it can actually improve their quality of life. So we need to find out what the patient wants to do, like a goal. It may be, if a patient has arthritis, maybe they just want to walk around their house, or maybe, they want to go pick some flowers from the garden. So just kind of working with them and saying, okay, well, this medication that's prescribed for your arthritis is going to help with, inflammation. It's going to help with joint pain, or, this prescribed, medication in conjunction with PT can help you have, a better range of motion so that you can do these things. So they're more likely to actually have, some buy-in and actually take that medicine. And we also need to implement strategies for medication success. That's a mouthful. And this includes investigating the possible barriers to a patient's success. So discuss with the pharmacist or healthcare provider, the need for sometimes a simpler medication regimen. So maybe instead of taking that blood pressure pill 3 times a day, maybe the patient would benefit from an extended release where they only have to take it once or twice a day. And then sometimes combination medications can work. But the downside to those are that sometimes they're a little bit more expensive, so the patients can't always, afford them. And then also pre-filled medication packages. Certain pharmacies and certain drugstores will actually fill blister packs for all the patient's medications. So, for example, if they take medications, morning, noon, and at bedtime, they will have 3 separate blister packs. So all the patient has to do is pop open the blister pack for that day, and all the medications they take in the morning or all the medications they take at noon or night are in that blister pack. So there's no opening bottles and getting a pill out and then dropping the pill on the floor, those type of things. And so blister packs or pre-filled medication packages have been shown to increase medication compliance. Now we also need to assess the technique to safely administer medications. So for example, can the patient actually draw up that insulin, or would they benefit from the insulin pen, or they have to dial the number of units and then inject themselves? Sometimes they may be able to do that, but they may not have the dexterity or the eyesight to be able to see the tiny markings on an insulin syringe. And then for memory issues, of course, we can always consider setting an alarm. We can always do, automated phone calls to remind the patient to pick up the medication from the pharmacy or get their refills. And then sometimes even a calendar. So we can make a pill calendar, and the patient can put it in the refrigerator and mark it off when they've actually taken the medication. And then last but not least, we can stress the importance of avoiding polypharmacy. So for example, we can encourage the patient to get all of their prescriptions filled at one central location or one central pharmacy to, avoid confusion and hopefully avoid, making, polypharmacy type errors. And then we have medication teaching. Teaching is a big, important step in, for the prevention of medication errors and medication safety. So obviously I can't stress enough that teaching begins when a medication is prescribed. Just like a person's discharge plan starts at admission into the inpatient unit, the medication teaching should begin as soon as that, within that first dose of medication. So this means we should take every opportunity to teach the patient as they arise, or sometimes every time a medication is administered. It should also be done the same way on each shift so that we have consistency. And I know there are times where you can't have a long, drawn-out, teaching session because patients are in pain, or they're tired, or they're just not, sometimes, quote unquote, feeling it at the moment. But always try to slip in those little nuggets of teaching, wherever we can. So, for example, maybe the first time you give them medication, you tell them the drug name. This is your furosemide, or this is your Lasix. Then the next time you may get into the purpose. And then, the next time that medication is prescribed, you may tell them, side effects of that medication to look for. So just repetition is sometimes the key to helping patients, understand, the purpose and function and side effects. Another thing that we need to do to help ensure a smooth teaching process is to assess our education materials and make sure they are tailored to our patients and our caregivers' needs. So a lot of times our medication materials or our education materials are written at such a high reading level that it doesn't matter if we have a really good handout, but if the patient can't understand it or their caregiver can't understand it, then we're not doing them any favors. So we need to make sure that the material is written in plain instructions. And we need to consider the actual education level of our geographical area. And then we also need to make sure that the teaching plan or our handouts are not written with a lot of medical abbreviations. So for example, a patient, a caregiver, they know what 3 times a day means, but they don't know what TID means. And then keep in mind that the patient's primary language should be used. So if this isn't English, then we need to print out their instructions in a language that they understand. And also using multiple learning modalities can also help reinforce education. And it can increase, better medication compliance. So the multiple modalities that I'm talking about include, visual aids, as well as, auditory, the hearing of the actual instructions, as well as being able to read, and then, the hands-on learning, where they actually, have to draw up the medication or, use that medication. So hands-on learning is very good for, inhalers. It's good for, insulin syringes, insulin pens. It's also good for the patient to demonstrate being able to open, standard pill bottles, those type of things. And research shows that you need to hit on at least 2 or more modalities to have successful education. So for example, your education sessions maybe should include visual aids and hands-on learning. So maybe some step-by-step instructions that the patient can actually follow. Or if it is a verbal session, then you also need to follow that up with maybe some reading materials that they can read at a later time to kind of help allow that to sink in. And then, of course, we always, as nurses, we always need to, evaluate and clarify our instructions. Maybe the patient didn't, or caregiver didn't hear our instructions correctly, or maybe they misunderstood. So we always need to evaluate their teaching, whether it be a short questionnaire or a short return demonstration session, and then we need to clarify any misconceptions or difficulties that that person may have. So last but not least, one of the keys to safely managing medications is the transition process. So the transition process is basically the next point of care. So once we discharge this patient from our ER or from our inpatient facility, who is going to follow up with that patient? Who is assuming care or responsibility for that patient? So lack of communication with that transition facility results in loss of information or fragmented information, and it increases risk to that patient, and it also increases the risk that that patient is going to return to the hospital. And as we know, anytime a patient is admitted for a circumstance that could have been prevented, Medicare and Medicaid and insurance doesn't like to pay for those stays. So to help with that, all logistics should be the same for any transition to the physician's office, to a nursing home, to a rehabilitation center, or discharge to the patient's home. So for example, some places actually have a checklist for their staff to make sure that all the key points are covered. We need to make sure that they do have all of the discharge paperwork, including the discharge summary, the complete physician's orders, the most accurate medication reconciliation, and then also we need to be proactive and diligent in scheduling a follow-up appointment, or help the patient make the appointment rather than just giving them instructions to call for an appointment, because we all know that sometimes that doesn't always happen, and they do need those follow-up appointments with the healthcare provider that is going to be assuming responsibility for them after their hospitalization. And then lastly, assess the transition environment. So for example, if a patient is going to a skilled facility such as a nursing home or rehab, assess their equipment and their ability. For example, talk to that charge nurse or the social worker that is handling that transition, and make sure that the facility has the appropriate medication for the patient so they don't miss doses. So for example, if they do not have, a patient's going to go get IV antibiotics because they have an infection, and they do not carry that medication routinely, then we need to work with that facility to make sure that the medication can be delivered and can be accessible, so that way when the patient actually is discharged and they do get to their facility, they're not skipping any medication dosages. And so that way their disease process is better managed medically. And it can also, again, avoid unnecessary admissions. So this is all that I have for you. I hope that this was helpful, and I hope that this continuing education does give you some food for thought and help you maybe see or get some ideas of things that you can implement in your own facility as well as your own practice. So please, if you have any questions or any comments or feedback, please email me at jennifer.morrell@abac.edu. Again, thank you for attending this continuing education lecture.